Justin, what's your initial approach to the management of patients with ovarian cancer with advanced disease?
So we talked about the cornerstones of treatment are surgery and chemotherapy, and the first question is, which are we doing first? And that'll be based upon several factors. One is the overall condition of the patient, and not just physically or from a nutritional standpoint, but also mentally, spiritually, as Anya alluded to. What is the patient ready to assume? What can she take on at that time? And then there are other variables that come into play in terms of the extent of disease present on imaging. Are there some signs that indicate we might not be able to resect all of the cancer, or that the operation might be an incomplete operation? There are no great predictive models for that, so we can't predict that with 100% accuracy, but we do know that there are some findings on imaging, or sometimes if we do a diagnostic laparoscopy, that can help us predict where do we triage our patients first, whether it's to chemotherapy or to surgery. And then once we make that decision, if it is surgery, which is oftentimes the bias, the goal then is to remove all the disease at that time. That can then be an extensive operation where we can remove a segment of intestine or a spleen or a portion of the liver to really get to the point of no obvious visible cancer remaining. And so those operations require stamina as well as patience to get through that.
So one of the obviously discussions today is the potential role for the so-called neoadjuvant chemotherapy. My own perspective on that is the surgeon. And just as you said, as a medical oncologist, I don't operate. So I would ask you, do you believe you can remove the gross disease? And if the answer is yes, that's an absolutely reasonable approach. And your statement is, it's going to be tough for whatever reasons, either where the disease is or concerns about the comorbidities, then chemotherapy seems like a reasonable approach. There's obviously a difference of opinion as to which patients fall in which category, but there's currently data that suggests that patients who get chemotherapy first can do quite well.
Correct. And that's, I think, there's been several studies that have come out to show that doing chemotherapy first does not appear to harm the overall survival. And I don't sort of have a dogmatic or, gospel approach to which is the paradigm that's best. It really is about the patient in front of me and what we think will get us the best results at the end of the day. And so, there has to be, I think, some flexibility in terms of one's viewpoint or standpoint on how you're going to treat the disease to really get to that end. And you're absolutely right. If I assess and determine I don't think that I can achieve a complete resection, whether it's based upon patient's overall health or whether it's based upon where the disease is, then those are the patients that we do triage to chemotherapy. And it also gives us a little bit of a trial balloon to see, is their disease responsive to chemotherapy? And that helps us to then go forward and know whether there will definitively be a role for surgery.
So I'm going to come back to Anya in a moment and on her 15-year journey. Just in general, sort of, what is her sort of therapeutic journey had been from your perspective? Then I'm going to turn around and I'm going to ask Anya's perspective on that as well. How has she sort of been treated and managed in general?
Sure. So I think one of the conversations we have early in the course when there's a recurrence of the cancer, and the risk is up to 80% for patients because they present at advanced stage. So we know most of our patients do recur. There is that small subset that doesn't, and so we certainly have to approach our therapy and our treatment plan as if we're aiming to get them into that minority. But the majority recur, and we talk about recurrence, the treatment paradigm shifts from talking about cure, and it's more of how are we going to treat and manage this disease. And so when we start down that journey, then we know we're always going to be vigilant, and there's always going to be some type of follow-up, surveillance, and then there will be periods of very intense treatment. So Anya's had periods where she's had, an operation followed by chemotherapy, or an operation followed by a clinical trial of a vaccine therapy that we had done for her. And so during those periods, it's very intense. We are, compromising quality of life for those time frames to some extent. But fortunately, we've also been able to achieve remissions and intervals where Anya's not on therapy. And she's certainly living her life. She's following up with us. We're continuing to do our surveillance. We're continuing to talk about what do we do when and if. And the interesting thing is, since her last operation, we've had 4 new therapies approved that could potentially impact her care, with both PARP inhibitors as well as an immunotherapy that was approved depending upon her tumor's characteristics. So it's amazing from that standpoint, if you think about it.
So, and Anya, turning to you. So again, I keep, this 15-year, I use the term journey. I don't know if that's an appropriate term, but it's been a number of years. And you've been through these various stages from your initial diagnosis to sitting with us today. How has your team sort of helped prepare you for the various steps along the way? Obviously, you've had surgery, you've had experimental therapies, you've had standard chemotherapy. How's your team work with you? How's all that happened?
Of course, the first line of defense is my husband, who is on my team. He's a tower strength.
Quarterback.
He's a great support. He goes, he searches for new treatments. He constantly gives me hope when I'm down, and that happens. And of course, second is my doctors. Dr. Chura, whom I trust wholeheartedly. He's been great, and I can't express enough how thankful I am to you, doctor. Of course, it involves a lot more than just a physician or gynecological oncologist. CTCA employs a whole team of nutritionists, of naturopathic doctors, even massages, which I didn't use much, and other modalities. That's very important, as well as your own way of life, your regimen. I put myself on rather strict, albeit enjoyable regimen of diet, exercises, and I think I'm doing quite well.
I would agree with that.
What do you think, Doctor?
Well, you just came back from China recently,
Yes, we
there
did.
for a few
Yes,
weeks.
we
So
did.
When you are talking about a new regimen, new strategy, are there specific questions you ask or you have asked routinely of each new strategy that's very important to you? In other words, something has happened, there's a concern for the potential for another treatment. Dr. Chura may present it to you. What's particularly important to you in those questions?
Actually, when I come to my doctor, I always have a list of questions. I do get prepared. I actually would tell everybody to do just that. Prepare for your visit. And of course, I go down the list with all the questions. I ask about the questions of efficacy, of quality of life, that sort of questions. I'm also interested in the whole regimen, exercises, nutrition, and any other adjunct treatments that could be there.